Welcome to the deep dive. Today, we're taking a bit of a shortcut, really, through a really important but maybe sometimes overlooked section of psychiatric thinking. We're looking at a key chapter from Kaplan and Sadock's comprehensive textbook of psychiatry.
That's right. We're diving into these conditions that, well, they aren't formal mental disorders in the usual sense, but they absolutely demand clinical attention. Think of them as the non-disorder codes, the ones that often tell you so much about the patient's actual situation, their context.
Okay.
So our mission, if you like, is to get a handle on how these additional conditions, and there are quite a range, from deliberate deception to cognitive limits, even family chaos, how they really shape the whole process of diagnosis and treatment planning.
Right. So we're going to unpack things like malingering, why that's different from a psychological issue, maybe touch on the biology behind some antisocial behavior.
Exactly.
Got
And also look at the vulnerability involved in things like borderline intellectual functioning and those really complex relational problems.
Got it. Let's start then. Malingering. That's code Z76.5.
Yep.
This is defined as intentionally making up or really exaggerating symptoms, but the key is it's driven purely by external incentive.
Purely external. That's the textbook definition. Think avoiding military duty, getting money, evading prosecution, maybe trying to score drugs. It's huge in forensic settings, as you can imagine.
And the symptoms are supposedly under voluntary control.
That's the understanding, yes.
Yeah.
Voluntary control, tangible goal. Now, the confusion often comes in comparing it with factitious disorder. People mix these up all the time.
Yeah, I was going to ask, because on the surface, they both look like someone's faking it, basically. Where's the actual line?
It's all about the motive.
Yeah.
It really is. Malingering is chasing that concrete external reward. It's a behavioral endpoint. Get the money, avoid the jail time.
Okay.
Factitious disorder, though, that's about the psychological reward. It's about getting into the sick role, wanting the sympathy, the medical attention. It's a psychological endpoint.
So one wants a check, the other wants, well, the attention of being sick. But, I mean, in a real clinic, how often are those motives completely separate? External gain versus the psychological need. Does that neat line always hold up?
Rarely.
Right.
Honestly, rarely. And that's what makes detection so tricky. Forensic evaluators have specific things they look for, these sort of red flags.
Like what?
Well, they look for someone reporting really rare symptoms or combinations that just don't make clinical sense, or endorsing just this grossly extreme severity that doesn't fit any known pattern for a disorder.
Right. Off the charts kind of symptoms.
Exactly. But probably the biggest indicator is a major inconsistency between what the patient says is wrong with them and how they actually behave, what you observe or what, family or friends report about their day-to-day functioning.
Okay, that makes sense. You mentioned a case in the source material. An attorney, middle-class guy, wanting stimulants for what he decided was adult ADD. That sounds like it muddies the waters a bit between external and internal goals.
Oh, that case is a perfect example of the complexity.
Yeah.
Yeah, this attorney, he'd seen several clinicians absolutely insisting on his self-diagnosis.
Right.
And when the psychiatrist did an assessment and suggested, look, this seems more like anxiety, maybe some mood instability, not really classic ADD, the attorney actually agreed with a lot of the specific clinical points. He said the insights were skillful, but he then declared the overall assessment perfectly flawed.
Perfectly flawed. Why, if he agreed with the points, why reject the conclusion?
Because the motivation wasn't just simple external gain like getting stimulants, nor was it purely the sick role. It ran deeper. It was character logic. You had this underlying narcissistic pathology, this need to control the expert, to stay one up, basically. That need was stronger than actually getting the right help.
Wow.
So he wanted the drug, yes, but he also needed to be right to win the interaction. It shows how these external goals can get completely tangled up with deep psychological needs about self-image and control.
Okay, that really highlights the complexity. So that covers sort of deliberate deception or at least complex motivations. Let's shift gears a bit. What about behaviors often just seen as bad choices, like adult antisocial behavior, criminality, and violence? The source material seems to challenge that simple bad choice idea pretty quickly by bringing in biology. Is this where we move from choice to constraint?
That's a great way to put it, yes. It's a crucial conceptual jump. We might label this as a condition not due to a mental disorder, but the research just shows layer upon layer of nuance. Take organized crime, for instance. There was a fascinating study mentioned comparing incarcerated mafia members to sort of ordinary criminals.
Okay.
The organized crime group actually scored lower on psychopathy scales. They showed more traits like caring and empathy, things you might actually need to run a successful, albeit criminal, organization. It suggests a difference between, let's say, strategic planned malice, and just impulsive chaos.
That is interesting. And it's not just street crime, right? The text talks about white-collar crime, the Dalkin shield, the OxyContin marketing. The costs are enormous, financially and in human terms.
Absolutely enormous. Hundreds of billions, potentially.
Huh.
And the human suffering is immense. And this connects, surprisingly directly, perhaps, to the neurology of how we make moral judgments.
How so?
Well, the sources really emphasize that morality isn't just some abstract concept. It involves sophisticated judgment, and that's heavily linked to the prefrontal cortex, the PFC.
Right, the front part of the brain.
Exactly. And when the PFC gets damaged, the brain's ability to generate that kind of gut-level negative, aversive response to doing something harmful,
Yeah.
it gets seriously impaired.
So if morality has roots in the physical brain, in the PFC, doesn't that kind of shake the foundations of, legal ideas about free will and being responsible for your actions?
That is the core tension, the philosophical conflict right there. The authors point to studies indicating that PFC damage early in life leads to much worse outcomes for moral functioning than similar damage occurring in adulthood.
Really? Early damage is worse.
Far worse, it seems. If the brain's very capacity for learning moral rules is structurally limited from early on, then the individual's capacity for responsibility is arguably limited too. It's incredibly complex. And this complexity is probably why the source material is so critical of just slapping the label psychopathy on people.
Yeah, you mentioned it calls that a lazy diagnosis.
Precisely. The argument is that many people dismissed as just psychopaths using things like the hair checklist. They might actually have identifiable, even treatable psychiatric disorders. Things like bipolar disorder, maybe psychotic disorders, even brain injuries like frontal lobe dysfunction.
And those get missed because the label seems to explain everything.
It can stop the investigation, yes. The evaluator sees the behavior, applies the label, and doesn't dig deeper for underlying treatable pathology.
So brain structure can be a constraint. What about temporary chemical issues? The text had that really disturbing example, didn't it? A law enforcement officer, good record, suddenly turns violent.
Ah, yes. That case perfectly illustrates how what looks like pure evil can actually be severe drug-induced psychopathology. Here's this officer, decorated, impeccable history, and suddenly he's exhibiting wild sexual behavior, aggression, escalating to violence, and even homicide.
Terrifying. What was going on?
A deeper look found he was taking absolutely massive doses of over-the-counter bodybuilding supplements, things containing ephedrine and caffeine, trying to cope with long shifts. This chemical cocktail basically triggered a severe manic psychotic episode in someone who, it turned out, had a genetic predisposition for bipolar disorder. His horrifying behavior wasn't innate malice. It was a severe treatable illness precipitated by the substances.
Wow. That really drives home the point about looking beyond the surface behavior.
Okay, so we've gone from complex choices to biological constraints. Let's talk about something maybe more foundational. Borderline intellectual functioning, BIF, code R41.83. Why is this developmental limitation so important clinically, even if it's not technically a disorder? Because it's such a significant, often hidden risk factor. BIF basically means intelligence that's well below average historically, IQ roughly in the 70 to 85 range. But, crucially, it's combined with real problems in adaptive functioning, how they cope day to day.
And what does that lead to?
Well, this marginal ability often results in chronic failure across different areas of life: school, work, relationships. This leads to low self-esteem, frustration, emotional distress, because they simply struggle to navigate the complexities that most adults manage.
What makes it hard to spot? You said it's often hidden. It seems like it would be obvious.
You'd think so, but the clinical features can be subtle or misinterpreted. We see things like very concrete thinking, they're slow in the uptake, poor attention, easily frustrated. But the real challenge, the thing that masks it, can be what's called compensatory verbal fluency.
Meaning they talk a good game.
Essentially, yes. They might have quite good surface language skills. They can sound articulate, maybe even intelligent in casual conversation. But this can completely hide deeper deficits in abstract thinking, reasoning, problem solving. Clinicians can miss the core issue entirely because the verbal skills seem okay.
And the diagnostic focus has shifted a bit now, hasn't it? Less fixated on just the IQ score.
Absolutely. DSM-5 puts much more emphasis on assessing adaptive skills, looking at conceptual abilities, social skills, practical life skills, and importantly, the level of support the person needs to function. This actually brings BIF much closer conceptually to a mild intellectual disability. It highlights that even if someone's IQ is slightly above the traditional cutoff for ID, they may still need significant services and accommodations.
So how do you intervene clinically with BIF? What does treatment look like?
Well, there aren't really specific formal guidelines, so the approach tends to be what's called multimodal risk intervention. It's about managing the associated risks. This usually involves providing very specific educational accommodations. And that doesn't just mean changing the curriculum, but changing how information is presented, how tasks are structured.
Okay.
And alongside that, psychosocial therapies are important, often aimed at improving inner resourcefulness, maybe addressing common co-occurring issues like alexithymia difficulty, identifying and describing emotions to help improve emotional regulation and stability.
So for you listening, the key takeaway on BIF is probably this: that verbal skill can really mask a fundamental difficulty in navigating life's demands. This leads to sort of predictable, chronic struggles unless the right supports are put in place and consistently maintained.
Real put.
All right, our last major area, relational problems. These are the V codes, right? Where the problem isn't seen as being inside one person, but between people. The relationship itself or the family system is the focus.
Exactly. The dysfunction is located in the interaction, in the environment.
Yeah.
But it still profoundly impacts individual health and treatment. These patterns are often long-standing, quite destructive. You see it clearly first in parent-child relational problem, or PCRP. This can come from really maladaptive parenting styles. Too authoritarian, too permissive, neglectful, or even smothering excessive overprotection. And the result is impairment in the child's behavior, their thinking, their emotions.
And then things can escalate when the parents themselves are in conflict. Child affected by parental relationship distress, VAPRD.
Yes, and the source material makes a critical point here. It's the high level of conflict between parents that predicts negative outcomes for the child much more strongly than the divorce itself.
That's important.
It really is.
Yeah.
When the conflict is severe, the child gets caught in this terrible loyalty conflict, trying to love and be loyal to two parents who are actively hostile towards each other. This is also where you can see really damaging scenarios like parental alienation, where one parent actively manipulates the child into rejecting the other parent, often based on false or distorted beliefs with no good justification.
That sounds incredibly painful for everyone involved. Shifting to adult relationships, what about relationship distress with spouse or intimate partner, RDSIP? What does that look like?
Well, RDSIP often correlates with certain personality traits, like high neuroticism or low agreeableness in one or both partners. Functionally, what you see is it quickly spirals into negative reciprocity, meaning negative feelings or actions are met with even more negativity. It just escalates. If that pattern continues, you get what's called cognitive cascading.
Okay.
Criticism turns into contempt. Defensiveness leads to stonewalling. Eventually, it's like all the positive memories or feelings about the relationship get completely erased or overshadowed by the negativity.
That sounds bleak. And it connects to another key concept, doesn't it? High expressed emotion, or EE.
Yes, high E is crucial, especially when dealing with severe mental illness in a family context. High E means high levels of criticism, hostility, or emotional over-involvement directed towards the family member with the illness.
And why is that so clinically relevant?
Because decades of research show that high E in the family environment is a powerful predictor of relapse, or even the initial onset of conditions like schizophrenia or severe mood disorders. It's a major environmental stressor. So a key goal of family intervention is often to lower that E, to help relatives understand the symptoms as part of an illness, not as a person being deliberately difficult or malicious. That shift in perspective can be protective.
It changes the whole dynamic.
Fundamentally.
Okay, so we've covered quite a landscape here today.
We really have. When you think about it, from the calculated deception and malingering to the neurobiological factors possibly constraining behavior and violence, the developmental limits of BIF, and then the sheer systemic pressure of these relational problems. All of these technically sit outside the standard list of formal psychiatric disorders. But, as we've seen, they form the absolute fabric of risk, vulnerability, and day-to-day functioning that clinicians simply have to engage with.
Yeah, and it brings us right back to that friction point you mentioned earlier about the brain and morality, choice versus constraint. On one hand, you have the legal world, the moral world, asking, was this a conscious choice? Is the person culpable, accountable? But then psychiatric science, especially with neuroscience and developmental research, keeps pointing towards biological constraint. Brain structure, genetics, trauma history, things that might limit truly free action. So the final thought maybe for you, the listener, to mull over is this. How does understanding these additional conditions, malingering, BIF, relational problems, the biology of violence, How does this knowledge actually push that boundary, the boundary between what society calls bad behavior and what might be better understood as a profound vulnerability, maybe even a form of illness needing support, not just judgment?
That's the essential question, isn't it? Really vital for anyone working in or thinking about mental health. Thank you for diving deep into the source material with us today.
Yes, thank you for joining us. Until next time on The Deep Dive.